Hello everyone and welcome to our prime time debate dedicated to the digital workflow for fully edentulous patients. To oversee the risks and limitations, the two scientific co-hosts, Bjarni Pjetursson, a typical analog guy from Iceland, and Vincent Fehmer, a master dental technician from Switzerland, have invited three experts. Tali Chackartchi from Israel, we have Tahmaseb from the Netherlands, and Sergio Piano from Italy. Good evening to you all. Bjarni, would you like to introduce tonight's topics for us?
Yeah, so what we are really going to look at in this primetime debate is whether it's possible to use the digital approach in implant dentistry to go through the entire workflow of a totally edentulous patient. We know it works when we have teeth as references, but I think this is a really big challenge.
Mm-hmm. Yeah, we learned that just in the Is It True session as well. Very challenging environment. And we would like to put you at this table as well by again introducing a vote for you. If this is the first time you come across this, you can scan the QR code, which is now on your screen. And if it disappears too quickly, it's also available for you right below the live stream player. And when you scan it, you find actually two questions that we want your answer on. And we'll discuss the different answers at different timings during this debate. The two questions you will find is, first of all, the overall question of the debate. Do you believe that it's possible to use a digital setup in an edentulous patient? Would you say yes, no, or perhaps you say, well, I don't know. I'm going to make my decision based on what I hear tonight. And the second question you find is based on the materials. What restorative material would you use in a full arch implant supported fixed dental prosthesis? Please take your time to vote. And Bjarni, you will call up when we discuss the results.
Yes.
But I think it's a good moment to get into our first slide, and I think it also addresses very nicely your thoughts on this, Tali. But let me introduce it in a way that we see all these little icons, and they have been there for 10 plus years, and still today we sit here in Paris, and we wonder, is it possible to connect those icons? We have everything here on the screen, perfectly functioning. But Tali, what do you see as the major challenge once applying those tools in a daily routine, in your hands, focusing on your dentistry?
Absolutely, Vincent. We are integrating digital tools in our everyday clinical work more and more. And the digital tools are amazing. They should help us enhance our knowledge and capabilities to maximize our experience into an optimal treatment plan. However, these digital tools have some limitations. The better we will understand these limitations, the better we will be able to control it, and we will get a more accurate treatment outcome. Now, most of the digital tools that we have are facing the same challenges. We are working in a physical environment, in the mouth of the patient. And once we are using the digital tools, we need to go into a software. But to get into the software, we need to transform the information from the patient's mouth reliably onto the software. Then we do our planning, and we need to go back again to the patient's mouth. These two leaps between the physical environment into the digital world and then back again to the physical environment, they require a lot of attention and a lot of experience in order to get an accurate treatment outcome from the digital tools. Well, the same goes for guided surgery. We want to plan a guided implant surgery. So we need to create our treatment plan. For that, we have to make a digital file on the software in a reliable way. So we would first need to have the CT scan of the patient. We would like to have a model of the patient that will be taken either with an intraoral scanner or in a conventional way, and then casted and scanned to an STL file. And of course, we have to know also the destination, where we want to be. And that will be our wax up. Now, once we have all of these parameters lining up together, we can superimpose that on the software, match it together, and now we have all information in order to optimize our implant position in the correct angulation, in the correct 3D dimensions, taking into consideration the treatment outcome, the outline of the prosthesis, as well as the limitation of the bone. Now we did a perfect planning and we want to go back to the patient's mouth. So we create virtually a guide, and this guide is going to be either printed or milled and used during surgery. But this second step, when we move out of the software, out of the digital world, back into the physical world with these guides, need calibration, needs verification. We have to make sure that the same way that we planned our guide is going to be the way that we have it in the patient's mouth. So as long as we have teeth, we can calibrate these two lips with using the teeth for data calibration and also for the position of the guide. But what happens if we don't have teeth, if we're in full edentulous case?
I think we know pretty well now that with good references like teeth, then we are in a pretty safe pathway going with a digital workflow, really from A to Z. But for me, when I have a dentulous patient, then it's a little bit different story. There are other issues here. First, when we are treating a dentulous patient, we are having real influence on the face of the patient, more than when we are doing 1 or 2 implant crowns. And then my real problem here is when I have a completely edentulous jaw, I feel a little bit like being in the desert. We don't really have deserts in Iceland, but I'm still a little bit lost.
A lot of open space.
Yeah, we have space to get lost. And it's a little bit the feeling when you have this situation. Where are you going to put the central incisors? Where are you going to put the canines? You have absolutely nothing to refer to. And that's the problem we are going to discuss here tonight.
Yes, because it is mandatory to plan. If each patient is different one from the other, with their own expectation, their own needs, their own requests, and their own facial expression, as we can see in this video. And so we have to avoid the standardization of the treatment and decide when it is required fixed or removal treatment, and you must be on the safe side and to choose what is appropriate for that specific patient. And the best analysis you can do is, and the easiest to do, is to take care of the facial profile. The facial profile is not new. This analysis, I think, is important to understand that the perioral tissue support is the key for the choice of restorative treatment. 3 factors comes into play: the vertical position of the bone bases, the horizontal position of the bone bases, and the position of tooth emergence. By analyzing the combination of these 3 factors, you can understand if the facial profile must be maintained or must be changed in order to offer to the patient the best performance in terms of aesthetics. I can make 2 examples of 2 opposite cases. The first, when we have the vertical dimension of the bone bases well maintained, as the same can be said for the horizontal position of the bone bases. And if we place the tooth emergence in the right position, we can end up the case with a fixed full arch rehabilitation in order to offer to the patient the best facial profile. So in this case, a fixed rehabilitation is the best one. On the other side, we see another completely different case. For instance, when you have a huge loss of bone, both in vertical and horizontal direction, and if we place the position of tooth emergence on the right base, on the right position, of course, the support of the lip cannot be ideal, and neither full arch bridge nor hybrid bridge can give the right support to the lip. And in this case, we need a flange, and if we need a flange, we can move toward a solution that must be removable, so over-dental implant support or something like this. And this is important to to understand this point, because even if sometimes the patient asks for a fixed rehabilitation, sometimes the best solution for that specific patient is a removable one.
This is the things you have to figure out in a detailed, meticulous try-in or setup phase, actually to visualize that point for the patient.
Yes, in fact, this is important to start with a different approach. That means individualization of the treatment, because I said only a pre-visualization, the final result, can help you in understanding which is the best solution for that specific patient. So pre-operative prosthetic planning and pre-visualization of final result are mandatory for choosing the right treatment.
I think here we really have the first conclusion of the evening, because some of our colleagues, I remember I went to a course on guided surgery 13, 14 years ago, and the guy that was giving the course, he said, no, here we never do overdenture, we do fixed for every patient. And I think like the first conclusion is really you have to evaluate the patient, and you cannot give every patient the wounds, what they wish for are fixed. Because like you said, you're looking at the profile of the patient.
Of course. Avoid the standardization and go into personalization of the treatment.
Just a quick question on the slides you show. We talk about digital tonight. This animation of the lady, is that real or is that augmented reality?
It is augmented reality.
So it's one of the ways you're also using digital, not in the job, but also to show the potential outcome.
Just to show to the patient,
We were not really very friendly to Sergio during the rehearsal today. We asked this if this would be his wife.
No, anyway, but it's a great technique. It's beyond the topic, but it's a great way to use digital
in this
technology.
case, I would have choose another type of lady.
Yeah. No, I think we have to move on. We have to be really serious. And I think like my issue here being this more like an analog type of dentist is that I have not really figured out the way to do the positioning of the teeth, the setup of the teeth in a digital way. So you see, when the patient comes in, we have basically three situations. We have a patient with no teeth and really nothing. Or we have a patient with no teeth and an old denture. Or the third situation is we have maybe patients with 3, 4, 5 teeth that we cannot save. And I think then we can do something because we have references. But how do you tackle the problem when you have absolutely no teeth and maybe the patient comes in with an old, not so good denture?
Well, sometimes we can use the old denture as a reference, as a wax-up, but we should be very careful when we use these a denture as a wax-up. We have basically two main problems with that. The first is that we have to make sure that the denture is absolutely designed the same way that we want the final denture to look like. And if we are planning a fixed restoration, we cannot use the same old denture as a reference point, as a wax-up, since the position of the crowns on the ridge is not going to be the same. And this wax-up is actually worthless. But there's another important aspect that we need to keep in mind, that when we are using the denture as a wax-up and we send the patient to get a CT scan with the denture, sometimes these dentures are rocking and are not so closely sitting on the soft tissues. And like, for example, in this picture, in this X-ray picture, we can see that the denture is not sitting 100% close on the soft tissue. It has this small black void underneath it. Now, we are planning a guide according to that. We are planning implant position and then a guide. How can we make sure that we are going back to the patient's mouth with the guide in the same relations that this denture set on the soft tissues when we did the CT scan? So whenever we are talking about guided surgery, not only the surgical work has to be very meticulous, also the prosthetic preparations has to be really, really meticulous and taking into consideration all the small details so the final result will be accurate.
Sergio, how do you approach this setup of the teeth when you have like no reference points?
The first approach is all the time prosthetic, and the first things to do is a setup. And the setup can be interpreted in two manners. Thanks to this little trick, let me say, little tip, we can prepare a setup with a removal flange. It means that if you remove the flange, you can check a fixed solution. If you put in the flange, you can check again a removal solution. This is the picture without the flange, fixed solution, with the flange, the removal one. It means that if you check it into the patient's mouth, then you move to the face in order to understand if this type of rehabilitation can be the best solution for that specific patient. If we check this, that is without the flange, so it means fixed rehabilitation, and we go to the lip, to the facial profile, to tell the truth, I don't like this. The profile is concave, the lip is very thin, so it's not, in my opinion, the best solution for that specific patient. On the contrary, if we put on the flange, you have a completely different situation with an appropriate bulky lip and also the good thickness. And this means that if I want to obtain the best aesthetic success in that specific patient, I have to perform a removal rehabilitation. In this case, the patient asked me for a fixed one, but after having seen this pre-evaluation, she decided for a removal one.
But you are still, I see you are going for the traditional analog way of setting up the teeth.
Yes, I have to say that I will show this in a case later. The feeling that you have in setting this setup in the patient mouth is completely different. You can't have the same evaluation and the same reply by using a virtual reality or something like this that project the image. I don't know your opinion, Vincent, but
no, there is no chance. You need the actual try-in, you need the actual facial reaction to it, the lip support, you need to evaluate it. There is no chance to visualize that, at least up till today.
In addition, you can also make some adjustment very quickly, yes, very easily, and in the reality, not by changing something on the computer. So this can give you the exact situation in your hand.
I think this is maybe, sorry Bjarni, one of the critical parts to address here. You know, going straight for printed mock-up, it seems to be very appealing on a digital approach, but on the other hand, it makes you very static once actually entering the clinical scenario. Yes, you can remove the flange, you can also grind it off, but then you're static with your teeth. However, in your kind of traditional setup, you will be able to play intraorally with the teeth just like we have learned it. So this is a huge advantage, actually contradicting here this digital workflow.
I think if I may interfere, I think it's the main reason to use digital is actually to make things easier. And I think digital setup doesn't make things easier. And it's nothing wrong with having small part of the analog, bring it in the digital ways and then put it, to the setup like this. And then you can avoid a lot of problems, but you can also create a lot of possibilities. I think as we all agree, there is no digital without analog, and there is no analog with digital. I mean, we need still both worlds, and nothing wrong with that, as long as it enhance and make our life easier.
I think maybe to conclude on this part, I think it's like what Sergio was showing, extremely important conclusion that if you are planning a fixed bridge, you have to show the patient how the facial appearance is going to change. Mm-hmm. I've had several cases that when this was not done, not my patients, but people were almost crying afterwards. They go through quite complicated treatment, and certainly they have no support for the lip. And so I think this step is extremely important. And I see we are still a little bit lost in the desert. There is a small tree there if you look in the corner. But how do you try to approach this, Ali, to
Yeah, I think I have to say, coming from a country with a lot of deserts, being lost in a desert is really not nice. I mean, I'd rather be lost in Iceland than in desert. So how we approach that is actually introducing mini implants of reference implants into the treatment protocol. And how many of them we need? We need 3, because also Tali mentioned, if you don't have any references, also on the surgical part, you are never sure if the surgical guide is seated on the on the position that you planned. So it's impossible, to my knowledge, it's impossible to be 100% sure that you have exactly the same place. So that's why we need, in my opinion, we need those mini implants. And we need 3 of them, because with 3 you can have a stable flat. And then you can use it not only for surgical reasons. As you can see here, we use the mini implants through the whole protocol. We use them to fix the setup to the patient. We use it for the data acquisition, because it's like a scan bodies that you can calibrate your images. You can use it to fix the setup to the patient. You can use them digitally to design your superstructure and your drills. But most important, as a surgeon, you have really fixed positioned drill guide during the surgery, which exactly mimics the position that you planned them. So that makes life quite easy on the surgical part and take a lot of problems away. And I mean, one can say, yeah, but there's a second surgery, but so what? I mean, there are so many second surgeries. If you look at orthodontics, they use also mini implants before going to the surgery. If you look at the other disciplines in the medicine, they also use different things to prepare.
It's also a very simple surgery.
It's a very simple surgery, and I think at least you have to, give that also as an option to the patient. And if you explain it right, and if you say it has a lot of benefits if you do so, why not? I mean, you can still use it. The patients that we treated during our program when we did the study back in 2012, none of them really had any problem to have those mini implants stay if you explain them in the correct way. As you can say, I mean, this is for me as a surgeon is like a fantastic that I'm really pretty sure, because I'm putting this mini implants, this drill guide on the mini implants. I'm pretty sure that my implants, at least the surgery, is going to go at least on the right way. So my implants had more chance to be on the right position.
Are you waiting for osseointegration? Are you using them more like orthodontic?
No, that's a good point, Bjarni. We don't wait for osseointegration. We don't want to keep them in the mouth. So you have to be quite fast during the protocol. Everybody has to be ready. I mean, in our study, we waited sometimes 3-4 weeks, but then you have a chance to lose an implant. If you lose one, it's okay, but if you lose 2, you have to go and start right over again.
Reference implant.
Yeah, if you lose them. So that's why you have to really keep the treatment as soon as possible within the range of like 2 weeks, that you go from the placing the mini implants right away to the placing the implant, which is technically is possible if you have everybody on the team on the right position and prepared.
Including the lab, I guess,
Yeah.
to be then on the spot. Because
Exactly.
also the transfer towards the laboratory using those or applying those mini implants helps really a lot to reassure the positioning of the setup.
But this is possible, Vincent, because the setup can be advanced in advance. I mean, you can do the dentistry in advance. Then you go the mini implants, you scan them, and the second moment you have already the information to the technician. And the designing of drill guide is completely digital. It's a CAD/CAM technology. It's if you have somebody behind the computer and you can design it in a few minutes, and let's say the next day you have already your drill guide. So it can go really fast. So.
Yeah, so I understand you prepare and then you have the dental technician ready. You start working on the prosthesis and everything else, and then the last day you use it as a reference point. You get that data, and then within 2 weeks we go in. So this requires quite some team coordination, I think, Vincent, with your experience.
But you see, this is the different when you see these partial edentulous or single crowns that we had on the first day. These full arch cases, if you want to put them all in one bin, the team has to be set up and prepared in a completely different way than handling the day-to-day cases.
Mm-hmm. Yeah, but because Ali, he knows he has a background in the desert. You told us.
Yeah.
So he
knows how important it is.
To have reference points. So I think that's the reason.
Mini implants in the desert all around the world. So.
No, I think so we see that I'm pretty proud now. I see that you need to go back to my world to the analog world to put the teeth in the correct position, because that's maybe the most easiest way to do it. And now we have the teeth in the correct position, so we move to the next step of our treatment. That would then be the surgery to get the implant in the correct position according to where we would like to have the teeth. So how do you now try to be predictable in this transfer from tooth position to implant position?
Well, first of all, of course, we have the mini implants and or the reference implants also for that stage. Since when we have mini implants, reference implants, we are, instead of having a soft tissue supported case, we are moving to an implant supported case. And, but there's also another alternative than to use these mini implants. In cases that I use an open tray that is not totally covering the ridge, I can use selective tissue stops that help me stabilize the guide on the soft tissues, but still leaves me some place to have a flap elevation, to have some manipulation of the soft tissue. So we can use that as well. However, whenever we are using tissue-supported guides, especially with no rigid reference points, we have to make sure that the guide sits stable while drilling, because we can distort the position of the guide also while drilling. When we are pushing on one side, it can be disconnected on the other side, and vice versa. So you can see on these videos through the process of drilling that I'm stabilizing the guide in a specific place. Usually it will be on the palate, because that's the most rigid part. In this case presented here, this lady had a very thick soft tissue in the anterior area. So I was choosing also the sequence of drilling and the sequence of implant placement according to that. Meaning that I first installed the posterior implants, then I used that as extra points of reference, as another fixation tools. And you can see that on the upper right picture, that I have vertical fixation going into the implants already placed. And now when I'm going to drill in the anterior area, I will have a lower risk of disconnecting the guide from the anterior, from the back when I'm pushing on the anterior area.
And Tali, sorry, what do you think about the use of fixation pins in order to augment the stability of the guide?
Thank you, Sergio. That's a very important question. Many times colleagues take fixation pins as a mean for calibration of the guide. It means that if we plan fixation pins and now we just put the guide in place, we can be sure that the guide is sitting properly. But we have to make sure without the pins, first of all, that we make that we insert the guide in a correct three-dimensional position on the soft tissues, and only then insert the fixation pins, and they will be just extra pair of hands to prevent from movement during these parts of drilling, as well as during implant installation, which also can change the position of the guide, because most of our implants now are self-drilling. So every step of the way has to be extremely meticulous and careful and passive in order to get to a proper end result.
Because I think, if I can ask you a question, I think it's important also that you kind of think about the strategy before going to the surgery. So you have to think about which implant should be inserted first in order to get the drill guide more stable, and the second. And I think you show it nicely because you think about it. It's not just like you have a drill guide, you can go whatever. You have to really think about, the strategy, kind of surgical strategy to insert those implants.
Absolutely.
So it's a little bit like going back to the old days when we were placing the old Brånemark bridges. You were supposed to tighten them in a certain, start here, you go then here, and then you go here. So here now you place the implant in a certain sequence that you get your guide always more and more stable for the next one.
Exactly.
To reduce the
So-
deviation as possible.
So what would be basically wrong is to drill for all the implants
Exactly.
with the guide just tissue supported.
Because you have to really stabilize the guide every time you drill, you place an implant, your guide is going to be stable. And then you go, again, even that you have to go strategically maybe to the other side, sometimes to implant in the front. It depends on the situation.
But when I look at this picture here, especially the implant in the lateral position in the second quadrant, it looks a little bit, it's out of the keratinous tissue. And my problem really with flapless surgery is that being a periodontist, I insist of having keratinous mucosa around every implant. So to do flapless, I need so much bone and so much keratinous tissue. So that is a little bit a limitation, at least in my mind. How do you try to do something to
That's
address
why I'm
this
using
problem?
an open tray, that it still gives me the opportunity to manipulate the soft tissue, like in this case with a small mini flap, and sometimes if I make punches just to suture the punches back, not to compromise the biology if we use this tool. It should enhance the result and not vice versa, not limit us.
So here we have your implants in position, 5 implants, nicely
Yes, so
placed.
eventually we have to realize that as long as we are working carefully through the protocol, we can be quite predictable. However, it will not be always 100% accurate to what we planned at the beginning. As we can see here, that the result between planning, which is the orange, and the actual positioning, which is the green, is quite acceptable. However, it's not 100% fitting.
So I suppose, Ali, you want to comment on this with your mini
eager
implants?
No, I just want to say it's true because if you look at the literature, there are a lot of publications, papers talking about inaccuracy. And we with ITI, we did twice a systematic review that we looked at the deviation between the planned position, that would be the green implant, and actually position of placed implant. And then you have these averages with outliners up to 7.1 millimeters, which actually means that I planned an implant in Gerrit's mouth. And at the end, I
have to move
I
like
placed
this.
I placed the implant in Bjarni's mouth. It's 7.1 millimeter. So, and if you look at why we have these discrepancies, I have to say that we can divide the deviations, the cause of deviations, 2 groups, the software and the hardware. And the software starts, for example, with the CBCT images, which can be really different in the quality within the different devices. You have different brands, but also within the same device, you can have discrepancy of quality, different in quality of pictures based on scan field of the view, the number of the metal restorations, but most importantly, maybe the movement of patient during the data acquisition, during the tomography. If patient moves, you end up in this kind of pictures, and you can imagine, you can appreciate that if you have these kind of images, you cannot really do anything. I mean, your acquisition is poor, and that has effect on your outcome. But also what Tabia Fluger showed us with her publication 2016, it's also important the segmentation of the images. Because a lot of softwares, they give you default segmentation. So you just push the button and they give you segmentation. And Tabia did a study when she compare the default segmentation with the clinical manual segmentation. So someone who knows the software and it goes and segments itself. And it's very important because if you look at the pictures, like picture A, you have the default segmentation with like, you know, you see the teeth somewhere, but you are not really can put a finger on that. And it's important because you need these surfaces, corresponding surfaces, to superimpose a CBCT image and an intraoral scanner. And if those images are not really clear, it can get you into trouble. And then you get mismatch between CBCT model and a surface scan model, and it results in deviation between the surface scan models after registration of CBCT model. It means actually basically that your drill guide fits well on your teeth because the drill guide design is based on your intraoral scanner, which is fine, but it doesn't mean that corresponding bone going to be the same as a real position. So you're going to have deviations already introduced before going to the surgery.
I mean, another point is who is actually doing the superimpositions. First of all, is it an automated process?
Exactly.
Who is referring to it? Is it maybe
Same.
even a support center, a dental technician handling those steps? So this can be very critical factors.
This is very critical factor, and I think it's important if you do guided surgery, either you know how to do it, or you ask somebody who does it who knows how to do it. Default segmentation, still up to date, is not really good enough. If you go to the hardware deviations, we can start with the drills. If you use this kind of drills and these adjustment handles, if you see it in the picture, you can have really deviation before you start. And as you can see, the study that done by Leuven, a group of Leuven, Van Assen and Kirene, they showed if you really exaggerate, you can end up in like 2 osteotomy sockets using one drill and one drill guide. Other thing is that they said, please keep the drill centered if you use those drills. If you look at the movie on the lower part, the guy is going in and out of drill guide. Don't do that, because every time you go out, you have to go in, and you don't center it, you are, creating another osteotomy. So this is important. If you're really doing this kind of techniques, using these kind of drills, you have to be pretty experienced and really be awake when you're doing these kind of surgeries. To attack that, you can use different kind of drills, which you can see here. There's drills that they have a guiding segment and a cutting segment. And the drill's length increase every time you go to the next one. In this way, you have complete guiding of drill. And because of you have the guiding segment, which is not cutting, the tolerance between your drill and your drill guide can be quite low. So it's just,
are we moving away from those spoons?
yes. I use these spoons because they asked me to use some
I have
companies.
a kit with spoons at home. So
Yes,
do you think I
use them
cannot
only
sell it after the show?
I use it also on
Hope they're not watching, Bjarni.
Okay, I can sell it to someone that's not watching. Have a very cheap
these
surgical kit.
These drills make sure that you have less inaccuracy, and it really helps if you do the surgery. Because I think, as we discussed before, I think every step is important. But the major deviations happen during the surgery. If you have a fantastic acquisition of your data, you did your best, you have excellent computer people, but still you are doing the surgery, you can really mess up your whole case.
It goes all to the extent of, the height of the sleeve.
Exactly.
You have in several positions, 2 millimeter, 4 and 6. It just brings up more potential for deviation.
From the bone, the bigger is the deviation.
Exactly. So the other thing is that I think is important, in my opinion, and what we did in our work is when you place the implant, you never know where to stop. What is the position, the vertical position of implant? As you can see here, I'm doing an in vitro study, and I'm really having a great sight because I'm looking at it, not in the mouth, but and you can see even by having a great sight, having great view, I am placing an implant, I stop what I thought, and I had the deviation and deformation of the drill guide of up to 100 micron. Imagine you have 6 implants, and every implant you have that deviation, you're going to end up with a problem.
And this is an extremely stable drill guide.
Exactly. And you can see even when you have this kind of computer animations, if you have, this is a drill guide made out of PIC, which is a really very stiff and very stable material. Fixed on the 3 mini implants, I am applying only 45 Newton centimeter, and you get that kind of deviation. So it's really visualized, you can visualize what the effect could be.
So when I listen to this with all those errors and problems, I'm just wondering, why are you trying to stick to this workflow? Why don't you come to me?
But you have errors. You have errors, but you can also counter those errors, as we try to show. For example, this is a very easy device that you can physically control your vertical positioning, as you can see here now in a vitro model. So you just activate the ring, and it goes around the implant mount. And when it reaches the desired position, it clicks on that, and then you stop. And then you have much less deformation of a drill guide. So it's an easy thing to do, and then you know exactly when to stop, and your deformation also stops.
Now, I know you're working hard minimizing those errors. And
yeah, exactly.
I think this ties nice into an audience question we get from Antoine Bernard. He has been watching all night, I think, also to the Is It True session, where we also had a session on the limitations of the intraoral scanner in fully edentulous patients. And the question of Antoine is it actually possible to deal with this limitation to perform a fully digital workflow?
I have to say to him that he needs to listen to the session for another 12 minutes. And then he will get
Stay tuned is your answer. All right, okay, let's move on.
How do you do
we
it?
are
Stay
in the
tuned.
last part.
So that's why we maybe, I mean, for me personally, if I agree with Bjarni a little bit, because why should we go all those problems that we can afford, we can counter and we can experience and still doing guided surgery. And for me was starting to do guided surgery in fully edentulous cases. So let me be clear, there's difference between fully edentulous and partially edentulous. There's fully edentulous cases that we thought if you really want to go through all this trouble, then I need, for me at least, I want to have like a final restoration or at least the temporary restoration already prefabricated. So that's what we did, and we thought to really minimize the errors by using the mini implants, using the mini implants and, why does it work? Yeah, using the mini implants and using all those drills and end up with a prefabricated restoration, which was placed directly after the implant placement. And we did like 40 consecutive cases, which we published back in 2012. And you could see that we could really achieve quite good precision if you really go all the steps that I told you. So for me, doing guided surgery, you need to do 3 things. You have to, if you go to the fully edentulous cases, you need to have mini implants. You have to calibrate the images. That's important. I think the usage of the low tolerance drills is extremely important. And also control the vertical position gives you really good tool to go very, very accurate.
I think maybe before we move to the second part of our session, I'm really curious what the audience says on whether you can go fully digital in edentulous patient.
Exactly. Let's take a look, Bjarni. I can tell you we're already almost in the last quarter of the session in terms of the time we have available. So let's look. We ask you to vote at the start of the session. We see a clear resolution. We have 70% saying yes, it is possible. And I must admit, I've been looking at the results. They cringed up a little bit during the session, but also the don't know was growing. So I guess we lose from the don't know. Some people start to doubt whether it's actually possible, hearing the limitations. But the majority of our viewers think, yes, this is possible.
Yeah, I think, listening to our experts, it seems to be the step of setting up the teeth. Mm-hmm. It makes more sense to do that analog. Mm-hmm. But I think we should maybe continue and see what people say at the end.
Sure. Everybody can still change their vote. Go to edit your response, and you can then change it from yes to no or to don't know even. All right. What's up next, Bjarni? Oh, you want to watch till they vote? Let's go back. Let's go, because otherwise we lose a lot of time. We don't have that much time left.
We would need maybe another slide and I think what we would like to do at the end here is to get Sergio to show us one case where he used the digital workflow as much as possible from A to Z.
Yes, this is the case. A lady with some hopeless teeth in the frontal area, they cannot be maintained, and of course, we cannot start from the surgical side. We need a setup, a pre-visualization in order to understand which is the ideal rehabilitation for that specific patient. And the first point is to take an impression. In this case, digital impression is perfect because allow the dentist to reduce the time. We can say one chair session, because at the same moment we can take the upper, lower, and bite, and so you don't need a resin mold to be prepared by the dental technician to be used in a second session. You do directly in only one session. The dental technician now is able to put these files into occlusion, and on this basis, the crucial point is to elaborate a setup. In my hand, as said before, the best way to do is to physically check it into the patient's mouth, because we have a sensation, we have a feeling that cannot be kept during the virtual planning. And so, in my opinion, we cannot have a perfect full digital workflow starting from A to Z, because, for instance, in this phase, we need this type of visualization. There are some teeth in the patient mouth, so we cannot extract to have a perfect setup, of course. So we need a visualization of the frontal teeth, and then we add the setup in order to have the perfect idea of what we need in this patient's mouth. And once we have decided, we have agreed this result, along with the patient, we ask the patient must be happy to wear this beautiful teeth and to have this situation, and we can forecast this situation in the final rehabilitation. At this point, this will be the base of the whole treatment. We can scan this setup, and we can import this setup into the software, and we can start to plan the position of the implant in accordance with the bone, of course, in accordance also with the prosthetic plan, the choice of the abutments, the choice of the position of the sleeves, and the fixation pin if needed, as in this case. Even if we have the remaining teeth still in position that give a rest to the guide, we need for helping the stabilization the use of fixation pins.
But this is one of the most beautiful parts once working with this digital approach in general. You have the full control. Even though the setup was in a way analog, still now you have in a way the chance to superimpose those different files, and then the technician on the other hand has then the chance to really come up with a final or a provisional prosthesis that is again copying exactly what we brought up in the beginning as a setup. So the strong arm here comes now again in the pros part.
Yes, and we move from the analog to the digital part, and then the dental technician is able to print the guide, the surgical guide as shown before. And in addition, he will be able to print also the model with the implant in position prior to start the surgical phase. And so he has in her hand all the data to produce a very nice provisional bridge, because on top of the implant, he placed the abutment that we have chosen on the computer. On top of that, we also placed the T-base, and then moving once again on the digital side, the setup is positioned on top of the model, and we can mill the provisional in accordance with the shape given by the setup. And this is the image related to the provisional bridge. We need the rest because we cannot afford to have the stabilization only of the occlusion, so you can do linking the bridge to the fixation pin if you want, or you can have more simply a rest on the palate in order to have a position that is stable.
I think, Sergio, it was an important point that Tali made, is that when you use those fixation pins, this is only as correct as your stabilization on the soft tissue when you fix the pins.
Yes.
But after you fix the pins, of course, then you are fixed in that position. But it's basically a tissue-supported position.
Of course, you must be very careful. It is one of the most important steps to be careful to fix the pin in a very correct position, because this is only a help to keep the guide stable and to work safer and smooth, because once the guide is fixed with the pin, you can play very relaxed. But this is very important to be sure that the position is really the correct one.
This is the critical part, because those guided surgery stents or splints, they have no prosthetic reference, you know. So in that moment, how to verify that really the midline is then in that position that, you know, we are aiming for, and all these parameters are kept into consideration. So I still see this as one of the tweaks that we have to overcome.
I think I mean, on a reliable manner, it's impossible to have it exactly the same position. It's just impossible. You just have to be hoping that you are within the range, not at 7.1 millimeter, within the range. So
Similar problem goes when you take out the pins during the surgery and bring them back again.
Exactly.
Then you lost everything. So trying to avoid that as possible.
You mean, Ali, when you have an edentulous case?
Edentulous cases, huh?
In this case, we have some teeth that give you the position.
Agree.
And you can help.
Completely agree. I'm talking about, because topic is fully edentulous, so I'm talking about to just give the message that is impossible. And I think we had a discussion this early in the morning. There are also studies and literature supporting using the pins as not really helping us at all.
Yeah. See whether Sergio got the implants in the correct position or not.
Yeah.
We have a case, you have to check very carefully the seat, the correct seat of the guide. And then another important point is to understand if we can go on with the flapless approach or not. We need to understand if we are on the right track, so if the position is correct. In this case, is not. And so here in the posterior, we have enough keratinized gingiva, so we can punch on one side, on the other side. In the frontal area is not the case, so we remove the punch after having cut with the punch drill. And then when we move to this area, thanks to the guide given by the surgical guide itself, we can release a very small flap in a way that after the positioning on the vestibular side, we have the implant surrounded on the fourth side by keratinized gingiva. This is mandatory if you want to have success. I never perform a flapless approach if I don't have an adequate amount of keratinized gingiva on the vestibular side. Then,
not to compromise on biology by using digital tools.
Of course, of course.
Do you have, Sergio, is it not always the issue when you have fully edentulous cases? Especially, because we only showed the upper jaws.
Let me only go on with the video. After replacing abutment and titanium coping, we fixed the procedure. You can see the precision of this procedure that need a relining procedure, but the reference point of the occlusion is very correct, and then this is a very fast procedure. Before, when I go freehand, look at the precision. When I go freehand, this procedure was very long, was very time-consuming. Now this phase is very fast and smooth. Few occlusal refinements. You can see the holes that are in the very right position, and then we can say that we obtain a very nice result. So, sorry.
No, my question was because we only showed fully edentulous cases in the maxilla. I think it's even more demanding when you go to the lower jaw.
Yes, it is.
It is for Geneva 2022,
exactly, so
lower jaw.
Going back,
yeah,
right?
with the topic.
This is totally different story on the lower jaw.
But Sergio, going to digital, this fancy way, it's a little bit old-fashioned doing this relining with acrylic in the mouth of the patient.
It is important if you want to be sure that you have raised all the little mistakes that you have in your planning. So from the planning stage, before, from the CBCT, the planning stage, the making of the guide, the surgical phase, you can add some little mistakes, and a very quick relining can solve the problem. So
being
the
compensation
that in my hand I like to do because I want to play safe and have a very passive fit of my prosthesis.
Could you even call this cementation and not relining?
Yes,
because
of course.
the space,
so yes, I agree. Relining is not the right word because the space is very reduced, so can be named the cementation.
I think maybe as a patient choosing between Alice mini implants and don't have to do this, and your slight distortion and you have to do this, I think it's up to Gary to decide which way would you like to go if you were the patient.
Be careful with your answer.
Referring to nationalities, I'd go for my Dutch fellow countryman and say, he told me it's a very simple surgery, we do surgery all the time, so I'll go with Ali.
For the mini screws.
If I can comment, you need a very motivated patient that would like to place 3 implants before starting any diagnostic procedure, because you can also end up without any implantation because there is no bone availability. So if you have a very motivated patient, this approach is perfect.
Yeah,
Okay, so now you have the implant in position, you have immediate loading with the provisional bridge. Can you show us the next step, please?
Yes. The next step is after the healing, the final impression. So we can go back to the initial question that in the Is It True session was made. The impression. It is possible to perform a optical impression in a full arch. It is very difficult. It is very difficult, and the reason is that the the oral scanner get lost into the mouth. By not having any reference point, it doesn't know if it is on the last scan body or in the frontal scan body, so a lot of mistakes can be added on the scan, on the scanning procedure. So we can put some tricks to try to correct this problem. One is to link together all the scan body with, for instance, interdental floss, and now the intraoral scanner can follow a sequence and understand where it is. Or another simple trick is to change 1 out of 4 or 2 out of 4 scan body of your company with scan bodies of other company that has a different shape, external shape, so the intraoral scan can understand that is another point, and the sequence can be read easily. It is not simple in the lower jaw, because in the upper jaw we have also the palatal wrinkle that can help the oral scanning, but it is a very difficult procedure. I have to admit this.
Because we asked the audience to vote on this.
You always need a verification process by using a test drive and something that can confirm that you are on the right track.
So you don't take like the intraoral scanning and you go straight and you spend like 1 week doing the final restoration. You have a reference.
You need to check. You need to check with the resin bridge, with something that can confirm the fit, the precision, and
it has to be a stable resin bridge. And the problem is, doing then the design, going back towards a malplaced or a wrong captured implant position is very difficult also for the software side. So, but in the end, I think it would be really nice to see how you finalize the case.
Yes. This is what the dental technician did by placing on matching, we can say, the impression taken in the patient mouth with the setup in this way, the provision that is the same thing. In this way, you have all the data on the virtual articulator. It can go on. And now we can discuss maybe half an hour more on the material, but we are lucky we have not the time to do this.
Of the platform, we can go on for as long as we want.
I think it's nice, and that's the reason we put like here we have next to each other 2 cases from Sergio. One was solved with monolithic zirconia, stained and glazed, and the other one has a metal framework and ceramic veneer. So if you just tell us, Sergio, what is your indication for zirconia and metal ceramic?
I think the best reply is there is no an ideal material that is okay for every case. You can, for instance, in a case with a cantilever, my choice is a metal framework in order to support the load. If I don't have any cantilever, I can move toward the zirconia bridge. For instance, if I have both arch, upper and lower, it is very difficult to perform a zirconia or a ceramic bridge because the cleansing of the arch is not very beautiful to hear, and so this case can be solved sometimes with the framework, metallic framework and composite. It is also a very interesting material because nowadays composite is not a second choice, and in addition you can also repair it.
So I think Sergio was really touching here a very important point, because if you do fixed restoration on implants in both jaw and you do it ceramic in both jaw, it tends to take 2 crystal glasses and you have cling, cling. So it's like drinking champagne the whole day, cling, cling.
That is
we
not
still
bad.
have a little bit to wait to drink champagne, Bjarni. I think we asked the audience in the beginning as well what they would prefer. I heard you say, Sergio, there's really no best material to say in general, and I think that's perfectly reflected by the results we see by our audience. They're all over the place. 1/3 votes for metallic ceramic. The 44% votes for the monolithic zirconia or the zirconia microveneered, and another little over 1/5, almost a quarter, votes for the metal resin or the composite. So I think this shows that we are at the end of this primetime debate in agreement on at least something.
Yeah, I think
Agreeing not to agree.
Yeah, I think, like Sergio put it, we don't have any ideal material at the moment. And maybe we would, if Vincent wants to comment on it, and when do we have to see the last 2 slides from Sergio, how he finalized the case.
I think we can
last
already
minute.
bring in the last slides to allow the audience to see how beautiful you finalized the case. I think this is a clear reflection of what we see. This is such a difficult topic when it comes to the restorative material, and selecting it correctly today seems to be not a solved issue.
And I think now we should really wrap up the session by changing back to the slides and see.
I think that the most important thing is the smile of the patient, because
Yes.
the patient doesn't care if the implant are tilted or are straight. The most important thing for the patient is that these implants are strong enough to support the bridge and to support beautiful teeth in a beautiful smile.
I think
All right, shall we conclude? We've covered many topics, from accuracy, micropins, yes, no pins, guides, how to drill your guides, the order of implant drilling.
And we finalized the session with a happy patient from Italy. I mean, it cannot be
Can achieve
better.
that? Exactly, we did well. So how are we in the desert?
I think we have few bushes to hold on to.
A few bushes to
And a
hold on.
bottle of water.
Yes.
Exactly. Bjarni, to wrap up the session,
No
final
problem.
word to you.
No, I think what we see here, we are on the right track, and we had the discussion this morning. How do you see this in 10 years? And I think we all think that in 10 years we will have a really nice digital workflow for all the steps. But I think we all agree today there is a certain step where it makes still more sense to go analog.
Yeah, exactly.
We are somewhere in the middle. Thank you so much for your extensive preparations for this nice ping-pong primetime debate, using all of your knowledge here in the middle on the table. And thank you for your interactive participation through the votes and the Q&A. This was the primetime debate of night 3.